Hi, welcome back. Sorry for the delay, everybody. Ledge Council is going to walk us through some of the changes on 190. And then we will hear from Boz on that. And it's posted on our website, our webpage. Is that called? Our committee.
Language. So for the record, Jennifer Carby, Legislative Council. Put the language up on the screen. The changes from the draft we looked at this morning are highlighted.
It's 2.3.
3.2.
So this 2.3 one's incorrect in front of me.
Yep, I saw it this morning.
You know, it's end of session when you
I don't
have
need a paper,
Monday
I'll be-
redrafts on your schedule. 3.2.
We're worried about AI centers.
Get rid of 1.1. Get rid of 3.1. Another change since then.
It's not 3.1 anymore either.
3.1.
I don't have to do it.
No, you don't. You're thinking copy.
All right, deep breath.
Okay.
I'm gonna do this therapeutic thing and throw out all the old ones.
Okay, so the changes since the last draft, there is I renumbered, I don't know if I remember that one. I added a new section 3. This is brand new, not highlighted in the section number line, but, and this is amending the cap on outpatient prescription drugs, hospital claims for outpatient prescription drugs last year in Act 55. The legislature enacted this cap on hospitals submitting claims to health insurers for reimbursement of outpatient prescription drugs in an amount that exceeds 120% of the average sales price for any drug for which the hospital charged any insurer more than 120% of the average sales price in effect as of April 1st, 2025. This would increase all of the 120s to 130s. And similarly, for any prescription drug in an outpatient or office setting that the hospital charged 120%, now 130% or less of the average sales price in effect as of,
Yeah.
as of April 1st, 2025, the hospital can't go up. Although in this case, they could go up from 120 to 130. I don't know if you want to speak to that part at all.
Okay, so we heard concerns, lots of numbers in here and a lot of stakeholders running a lot of numbers, trying to get an accurate number. The 3.5% that of the revenue of commercial revenue.
Net revenue.
Net, thank you, net.
All net patient revenue. Put it up now.
That got to an estimate of 56 million. And the currently it's there, you've committed to 50, correct? You've committed to 50. So there was a concern of $6 million. So rather than reducing the percentage of net commercial revenue that would then be put into the rates for the QHP market and the VHI, rather than changing that, I suggested that perhaps we can find another way to put that $6 million back in. And thank you so much for all the people who have been working really hard for the last couple of hours. It's estimated that if we increase from 120 to 130, it will net back in approximately that amount of money. Actually, I believe it a numbered a tiny bit, and I just said, no, we're not doing percentages. So, or points of things like that. So 130 would get us to that. So the net effect would be the same, but we have remained untouched with the 3.5%. So that's the reasoning for this.
So that's that change then, just renumbering sections until we get to what is now section 9 on the critical access hospitals. And I modified the intent language, so kept the same introduction part, but modified the intent aspect to say it is the intent of this section to provide information to Vermont seniors and other Medicare beneficiaries about the federal requirement, while a working group of interested stakeholders endeavors to develop appropriate and enduring solutions that do not undermine the financial sustainability of our critical access hospitals and that comply with federal law. Just trying to sort of flag that we are aware of the constraints there.
Is
And-
it just a grammatical thing? Would it be stakeholders endeavors? Maybe it would be, but
Well, it's while a group of interested stakeholders,
The group.
so it's endeavors as a verb.
Thank
Subsection B, I revised per your discussion this morning, on or before September 1st, 2026, each critical access hospital shall do all of the following. First is identify all of the outpatient services for which the hospital charges 5 or more times the Medicare allowed amount for the service. And then we have post prominently on its website and in outpatient departments at the hospital a disclosure about the federal requirement that Medicare beneficiaries must pay 20% of the charge for outpatient services at critical access hospitals, that Medicare beneficiaries may be able to receive care with reduced out-of-pocket costs from other providers, and how to contact the hospital's patient financial assistance department for more information. And it says the hospital shall file its proposed disclosure materials with the Green Mountain Care Board for the board's approval prior to post. Then for the effective dates, it would still all take effect on passage, except in consulting with the hospitals, but at least for now, that the section 3, that change from 120 to 130% would take effect on July 1st. And then I suggested for a title, an act relating to reference-based pricing and the Green Mountain Care Board. It's sort of generally reflective of what's in the document.
Thanks, Jen. Thanks for all your fast and furious work on all of this. Appreciate it. Would, Devin, do you want to come on up? Like, Jen, you guys.
But that's okay, I gotta plug in my computer, so it's slow.
you want to plug it in here in the meantime? Okay, because you're coming back.
Yes, I might bring it back up.
Yeah.
Thanks. Hi, good afternoon. Devin Green, Vermont Association of Hospitals and Health Systems. I do really appreciate the work on this bill. And the chair is correct that the 3.5%, as testified to today, I think was 54.6 million. The either 56.4 or 54.6, I can't remember. And then the hospital budget guidance impacting the critical access hospitals, that net patient service revenue, I believe, is about 3 million. So it is above 50 million, but we do appreciate the sort of inflation. The acknowledgement of inflation in the Act 55 prescription drug cap. I think that helps, and we are working with our hospitals to just socialize that a little bit.
Okay.
And as always, I will just say that we still have concerns about the Green Mountain Care Board acting on the critical access hospital piece. But we will continue to work with them within the parameters of federal law.
Do you support the new language?
I do support the new language.
All right. Thank you.
Thank you.
Really appreciate that. So I, unless anyone has any discussion, but would Blue Cross Blue Shield like to
Hi, everyone. Courtney Harness, Blue Cross and Blue Shield of Vermont. Fully understanding that we won't make any changes at this point, would like to make sure that for the record, everyone knows that this change to outpatient drugs on July 1st, 2026 will have a material worsening of the financial position of your domestic nonprofit insurer. And I wanted to make sure that everyone was aware of that.
But do you acknowledge that at the same time, the 3.5% will have a much larger effect in the other direction?
That's the purpose of reference-based pricing. Yes.
Go ahead, Brian.
Do you have a number? Do you have a number like of the impact, or is it just like a general idea?
This, I do not have an estimate.
If the hospitals estimate it to be approximately 6 million and you have what share of the market as opposed to of the commercial market?
60%.
60%. So it would be 60% of 6 million, which I'm not going to do math.
3.6 million.
Okay.
Good job.
And it would be for 6 months. So that would be probably 1.8. And then beginning immediately in 2027, you would hopefully be able to supplant that 1 point some loss with a potential 40 million, considering these two groups probably, if we're just guessing, maybe 75% of.
My understanding of the bill is the 1.8 million will come directly out of the money that I would assume go to our reserves. And as you know, we've had significant discussion in this committee this session about the solvency of Blue Cross Blue Shield of Vermont. I would reiterate for the record that this is a decision in the exact opposite direction. And I would say it's my understanding the intent of the bill is to reduce premiums with the cost savings at hospitals. I would not anticipate any of those dollars going to Blue Cross and Blue Shield of Vermont. That would be up to the Green Mountain Care Board.
What does, what the capping at 120 that we did, that went into effect in January?
Hmm.
What sort of estimation does Blue Cross Blue Shield of how much that has saved Blue Cross Blue Shield just in the first 5 months?
Seeing this language for the first time 8 minutes ago, I would have to run the numbers for you and get back to you.
What was the actuarial estimation of how much that act would have on?
Yeah, so that's a two-pronged question related to my last answer, which was we believe that there was an $87 million reduction in the ASP drugs, and Green Mountain Care Board did take that fully out of our premiums. There was no money that went to Blue Cross and Blue Shield from that reduction.
I just will reiterate that the actions of this legislature saved you 87,
No,
80
saved Vermonters.
saved Vermonters,
Mhm.
80 some million, and
Correct.
we're giving back 1 point some so that in 2027, you can then have probably another 40.
Not, for the record, again, not sitting here to argue, simply to make sure that the committee is aware that this date of passage, not anything to do with the number, the date of passage will materially weaken the financial position of Blue Cross and Blue Shield of Vermont.
Go ahead, Leslie.
I'm not sure it's a question for, I mean, it seems like both positions are weak. So it's the question about who's going to be weaker. So I think that I understand why we're moving in this direction. I was just wondering on the ASP, moving it from 120 to 130, I can't remember. And if you could remind me, was the 120 in perpetuity or was it a time frame? And so would it stay at 130?
Perpetuity.
So the 130 will stay in perpetuity until we
Yes.
change it.
Yes.
Okay.
Unless we change it. Would, may I ask may I ask you, Jacqueline?
Yes.
The date of July 1st. So your hospital budget orders,
Flexible.
you're flexible on the date?
Yes.
Would
Date of
we,
what?
of when this new price cap would go into effect, would you be willing to make it January 1st? Or October 1st?
Let's do October 1st and then, yeah, October 1st.
Can we do that? Jen, I am so sorry.
3.3.
3.3.
At the, section, let's see, so the hospital updates the AHP clearance drug annually on January 1st and July 1st based on CMS's
Oh,
ASP calculations for the most recent calendar quarter. I don't know if that,
yeah, that's right, because drugs are repriced every 3 months.
I mean, we could put in, you know, we could, if it seems doable from an implementation standpoint, I think we could just put it in the effective date. You know, we would take it back on October 1st, or notwithstanding this provision, we take it back on October 1st, and then it would be, you know, updated again in January when you're directed to update.
I think that was good. And Dan Green from Bugs, just to get the numbers right. We calculate this as having $3.6 million impact, total
To the PPS hospital.
to the PPS.
Which the cap only affects the PPS hospitals anyways, which is,
To the critical access hospitals that are connected to.
But not Brattleboro.
thank you. So we'll change. So any other thoughts? Okay, so I'm gonna hold off on a vote on this for a little bit. We can move on to 197. It's really important to me in this committee that, I mean, in my role, I try to make sure that we all have all the information that we need to make the best decisions on the bills we're voting on. And I value transparency and I value information. And in the effort of ensuring that all the members on this feel comfortable with all the information that they need to make an accurate decision that reflects their thoughts. I'm gonna hold off on the vote because I want members to be able to think and consult on this a little bit.
How long? Like till later today or till next week?
Hopefully within an hour.
Okay.
But guess what? We have a lot of work to do on S-197, so let's get to work on 197.
Can I say something, please?
Oh, yes, Val, of course, I'm sorry.
Alyssa,
Yeah.
Chair Black, thank you. I really appreciate you taking a breath on this. I think that says a lot for everybody, not only the committee, but everyone that has had a voice in this. I am a no still. I need time. I care about every stakeholder. I care about every Vermonter. And I just feel until I see Blue Cross and DFR and Devin sit in that chair across from you and they can pound their fists on the table and say yes. And that's what I need. So I appreciate you holding off for a moment until I hear from Rutland Hospital. They're trying to crunch numbers. I really appreciate that. And I do need to excuse myself. I need to go pick Hazel up and I'll join again when I get back.
Right, thank you, Val. Thank you. Kevin, did you want to come up and pound on the table? I was gonna say like, I don't want you to be like Director Olson or anything. Okay, let's move on to 197. Jen, if you want to come on up.
Yeah, and I continue to be 1 minute.
Yes, of
finish my
course.
thought on
Please.
this recommendation. I do. I'm gonna try and back up at 7, but.
Version of 197, which is probably buried under 10 versions of 190.
Well, look at 3.1, is that where we're at, you think?
It should be close
7?
197.
Yeah.
That's medicine.
Oh, that's the old got it.
That's what that.
But that's what we're looking at.
That's introduced.
Yeah, sorry. Oh, you want me to go? Well, we already started the bunch.
Okay. Got it. All right, do you want to put up the language? So we had pretty robust, excited discussion in committee. I think that was last Friday. And we, you know, after our public hearing, I think there was enthusiasm to sort of do some intent. Some language around where we think we might want to, where we might want to go with this bill. So I think that this bill, as came over from the Senate, you know, it sort of moved us kind of in this direction by sort of strengthening the blueprint and evaluating, you know, primary care spending. And I think that these are all really good things. So Jen, I think we should go through what's in the bill. And I also sent around, I'm sorry, Jen, can you remind me what the bill number was back in? S53 from 2018. And the whole committee was sent that bill. And it sort of provided a roadmap, which the bill did not pass at the time.
It's
So I
right in
thought,
House Appropriations, right?
so this is my thoughts around 197. I think we should go through. I think we should be thinking about things we might either remove or move around or maybe clarify what we're trying to do. And then I think we should put very strong intent language in where we're trying to get to, and then create a path so that we can have time to actually think about the various things that need to be thought of well and what needs to happen, and come forward with recommendations next year with something fully formed and fleshed out. Those are just my thoughts. Other people may have other thoughts. So how does everybody feel about that? Does anyone feel anything?
I feel great about that, Alyssa.
Oh, thank you.
I feel like it's a good process and that maybe we could try to filter questions and comments and really stay focused on the mission of, this isn't about getting into like philosophical debates about the meaning of a thing. It's about what belongs in here and what doesn't, to
Yeah.
meet the intent and we'll be as efficient as we can.
Make that happen.
Yes. let's make it happen. Sounds
In
great.
fact, we could set timers for ourselves. You have 30 seconds to make your point and the next person goes. And Tasha will ring a bell.
So I did work a little bit with Jen this morning, just sort of coming, and do you want to, and it's not a draft. So by any measure, am I right? But we did have some thoughts and ideas around, I was wondering,
I'd rather not put out my sort of shorthand notes on the document.
all right,
Are we working off 197 or 53? Or both?
197.
So,
I know that you don't want to post that, but would you mind sharing it with me so that I can have a recollection of what we might have talked about?
Process you described was using 197, right?
Yeah,
Okay.
Just clarifying your question.
Thank you.
Yeah.
and then we'll go through the language of the bill. And then
Great.
of 197 as,
Good lord.
Thank you.
and then at least I'll have my note, Jen's notes to refresh me on what some of my thoughts were. So, and I'll put them out there.
I just realized something auspicious. Do you know
Okay.
what 197 plus 50
So do you want to
is?
put up 197?
Yes. Sorry, I had it up and then I took it down to
250.
that's something to do with cost.
I was thinking more like Act 50, you know? Too soon.
Okay,
It is.
so it is the intent of the General Assembly to invest in primary care. Oh, that's right, I forgot that. I remember on your notes that was one of the notes. Primary care, there's streamlined primary care payments that build on the blueprint for health. I feel as, well, I think that if we're going to have intent on moving to a more universal primary care, I don't think we should be in intent language, like tying ourselves to the existing blueprint, because I think we should be thinking about all possible mechanisms for this.
Could not agree more.
Okay.
I'm with you.
Especially because we don't know what's gonna happen. I mean, look what happened to the ACO in the head. So.
That first.
So how would that, so does the intent to invest in primary care and streamline primary care payments?
Is there an intent section in 53 that we could look at?
Well,
there is.
there is. So we do have, I mean, this is not fully fleshed out, but I will say is that, and I know Jen doesn't want to put her notes up and I won't, but do you mind if I read like some of the thoughts that we had?
Sure.
Okay. It's the intent of the General Assembly to invest in primary care and to establish a program of universal primary care that is accessible to and affordable for all Vermonters. And will promote the public good by increasing access to primary care in order to improve the health of Vermonters.
Is that age 53 or, I'm sorry?
No, this is,
She had given me her thoughts this morning and I'd taken some notes and she's reading those.
reading.
I keep hearing people referring to 53, so I'm just trying to.
Oh, it was S53 of
Oh, S.
2018.
Oh, that
is the one.
Okay, I needed a little old, sorry.
When you all started
Old.
talking about universal primary care last week, Nolan and I vividly remembered working on this in 15, 16, 17, 18.
I'm gonna say something really probably controversial, but I really want people's thoughts on this. I object to putting in intent language, reduce healthcare system costs. I feel like, it's just my own thoughts. I feel like when you put your intention that you're going to be reducing costs, that the outcome and what you build and the direction you move it becomes focused on healthcare costs. And if we want to build a vibrant, public, accessible primary system of universal primary care, shouldn't we be focusing that instead of worrying about what it costs? If you invest, the cost savings will come, but that shouldn't be your intent and your purpose. Leslie?
So I agree with that as singly. I think that there's the triple aim or the quadruple aim, depending on how you look at it. The quadruple aim includes costs, but it also includes access, quality, and workforce satisfaction, for want of a better word. I'm not saying that's what we should use, but I think I think we should. I think we should look at all four.
Okay, so
That
let's,
would be my hope.
so, okay, so we want to promote public good by increasing access to okay, so we've got access,
Quality. Increase access, increase quality, cost, and improve workforce experience.
how about affordability?
I like affordability better than.
It's just got that particular
Yeah.
language, but I don't care. Whatever makes.
Affordable and, I'm sorry, access, quality, affordability, and,
Quality of
oh,
provider.
and,
And workforce satisfaction or workforce.
Workforce experience. There's something in, actually, AHS has language on the quadruple aim.
supporting and valuing.
It's the last one, right?
Healthcare
Supporting value on healthcare workforce so they provide excellent care and meet the ongoing needs of the people of Vermont. Now, I'm not saying we should use that language, but I think including the workforce there is.
Right, provider satisfaction or something like that.
I think workforce is broader.
That's fine.
Yeah, because it includes all the staff. Which we need all staff.
I think, okay, so let's think about how we can write what we can write. It's the intent of the General Assembly. This is going to be. I told you this is going to be.
It's a drafting session right now.
Yeah, this
Is that what we're doing?
This is truly markup.
Kill each other, but
It's the intent of the General Assembly to invest in primary care and to establish a program of universal primary care that is accessible
it increases access.
and affordable for all Vermonters. And will promote public good by increasing access to primary care, supporting primary care workforce.
I'm not getting all of this
No.
down.
No, what I just read, by the way, Jen, is what you have in your notes anyways.
I should use AI.
Until I said,
Yeah.
um,
Just to like. capture-
increasing access to primary care in order to improve the health of Vermonters, and then supporting
Improving
healthcare
provider
workforce and increasing quality, or
Increasing quality, increasing access, increasing workforce satisfaction, and reducing. Well, you want to say increasing affordability, or I'd say reducing costs, because I think people know what that means.
well, I think we already have in here that's affordable for all Vermonters.
Yeah. I'm not sure what's in there because I'm not looking right now.
I think increasing workforce experience.
Yeah, that's fine. Well, I don't know what increasing in experience means. There has to be a adjective.
Right.
Experience means how they show up at work every day.
It could be shitty experience.
Well, that's the language.
I think
Quadruple aim.
Increasing though,
What is the
maybe we could just say like,
Experience sounds like you're having.
Yeah, improve it. That's fine.
What's wrong with our guiding principles? Supporting and valuing our healthcare workforce.
Yeah, I like it.
I think that's about how what you're doing as opposed to what they're experiencing.
Supporting,
Improving the patient experience, improving population health, reducing costs, improving clinician staff well-being. That's the quadruple aim.
okay. Does everybody like that?
And improving the patient experience includes enhancing quality, safety, and satisfaction. Improving population health means addressing health disparities, improving outcomes. Reducing costs mean lowering per capita cost of care. And improving clinician staff well-being, addressing burnout, and providing a positive work environment. So that's sort of the summary of it, of the quadruple aim.
Where do I find the quadruple?
Yes, exactly.
I'll send it
Would you like to give Jen?
I will send it.
I,
Oh. I just would like to get it into 2 or 3 sentences.
Yeah, or,
Telling you, put it in AI, tell it to make it 3 sentences. It will.
yeah.
I'm putting it into Jen's.
And then Jen can look at it and fix it.
Tell Jen and put her to, tell her to put in the present.
Yeah.
Generate.
I love.
With that generative.
They are.
Can I just say- can I just say right now, like, I found that in the past, drafting sessions in the group this size is really difficult.
It is
time
very
consuming.
difficult. It is very difficult and time
We just
consuming.
spent 20 minutes on 3
Um,
sentences. and
I'm not sure how else to.
But these are
Yeah,
crucial, this is the crucial piece and the rest of it may flow.
Jen, can you actually type while you're on there, or is that a no? I'm sorry, I don't actually know.
I mean, I'm happy to work on things while you're talking. I'd rather not put the language up and
Yeah.
be literally,
Okay. Like we're
Coming
all
up
in
with
the same
things.
Google Doc or something like that.
Would it be possible that Tasha could put the bill up and Jen could type on the computer so Jen's not like trying to double fist typing
Okay.
and showing us the
or
thing?
So-
somebody else, maybe somebody else can still do the rest.
Yeah.
All right,
So
so
say this quadruple aim comes out of the Institute of Healthcare Improvement, which is a fundamental organization looking at healthcare improvement. So we might want to include Institute for Healthcare Improvement quadruple aim and then
I don't
describe.
want to name anybody. How about, can we land on those are the 4 things that we want to see?
I'm good with it.
Okay, and then we had a sentence in here at the end of the draft that Jen, it's not a draft, the notes that Jen and I were working on. And the last sentence was just the purpose of this bill is to obtain information needed in order to develop a framework for implementation.
Let me hear it again.
Or obtain the information necessary.
Purpose of this bill is to obtain information necessary to develop a framework for implementation of universal primary care.
Good with that.
Yeah.
So the legislative intent,
Right. Yeah, give me a second and I will tell you what I think I have, except I'm just gonna say quadruple aim.
okay,
Because I haven't gotten put all of that in yet. I would have, it is the intent of the General Assembly to invest in primary care and to establish a program of universal primary care that is accessible to and affordable for all Vermonters. I guess I need a beginning of the next sentence, but something will promote, or I guess we could just keep going, and will promote the public good by name. And then,
Principles of the triple aim.
well, I'm gonna put
Yeah,
them
you'll,
in.
you'll forget.
I don't have them in here yet. The purpose of this bill is to obtain the information necessary to develop a framework for implementation of universal primary care.
No.
I mean, it's just as,
As I'm writing, as you speak.
It's on the first sentence for it.
no, we're spending a fair amount, we're only on the intent, but frankly, that's what's really gonna matter.
Because most of this, we're just gonna review and decide whether we keep it or not, right?
Yes. So,
can I have the charger back or you?
no,
I have a chart. Oh, wait.
I was just fairly finicky. All right, great. I'm back down to
Okay, so when I went through, the language, let's let them get plugged in. I don't know that we see.
It is.
Or it wouldn't be this person. I would never get an appropriation for this, but I think that the General Assembly should have chargers every single place, so you don't have to walk around with chargers.
This is our perfect.
We have asked.
Can I have joint fiscal do a summer study on how much it would have cost?
Sure, but I need an actual,
Everybody would walk around.
In actuarial.
we need an actual analysis.
That's it.
You also do a cost analysis
Okay.
on.
All right, so go back to 187.
How about just third floor committee rooms?
So you want to put the language back up? Of 190?
No, 197.
197. Don't make me do that. Okay, so let's move on from the intent. As I went through the bill this morning with Jen, we made some notes on things and do you wanna, you wanna do just like a standard walkthrough of the bill, and then as we get to parts, let's sort of say stuff? Sure. I don't know what I'll say, but stuff.
Section 2 amends the blueprint subchapter, and it makes some modifications to definitions, largely just sort of standardizing them with what's in other places in statute, and spelling out the definition that is in 18 VSA 9402 rather than just cross-referencing it, because I think it's helpful to see what is in it. Including that it includes, to the extent permitted under federal law, third-party administrators that administer a health plan offering coverage in this state or provide administrative services only.
It's important. We kept all that.
Question about it.
Yes, of course.
So section 2, if I'm understanding it right, it kind of, if we adopt this, makes the assumption that the blueprint is the mechanism.
Not necessarily.
Well, that's what I'm wondering about. That's what I'd like to have. a
I think
conversation.
that's what you just took at least out of the intent.
Yeah.
Okay, but if we go with section 2, we're saying the blueprint will do it.
So far you are just, I mean, so far we have looked at definitions in blueprint. And I think one of the things we were looking at this morning as bright and early as we were walking through and or looking at the language in my office is that a lot of this is updating of this particular section is updating the blueprint. It's not really expanding the blueprint. It's
not making the assumption that the blueprint will be the.
No.
I would say some of the future sections do. I think this
Not this.
part that we're in so far does
When we
not.
get there, I'll say it again.
Yes.
Yeah.
I don't want that assumption.
I will tell you when I think we get there, which is
Yeah.
the new section being added to the subchapter. So you're in the right neighborhood. I don't think it quite does it yet.
But what if by having this section about the blueprint do for us?
Well, first
It
of
does say
all,
implement one or more payment models, so maybe it does.
yeah.
And
Yeah.
focus on
Thank
that.
you.
Yeah.
So we're adding this, 2.
Right, so 2 says, in order to facilitate development of the sustainable payment models necessary for the blueprint success, which is may not be expanding, but just making sure it's sustainable. Health insurers shall submit to the Agency of Human Services at least quarterly or more frequently upon the agency's request, all information that the director of the blueprint deems necessary to perform a comprehensive fiscal analysis of the total cost of care within Vermont. And then I think this is the piece where I go too soon. And to implement one or more payment models that address healthcare capacity, volume, quality, and clinical outcomes. So that may be going further than people want. Do you want to stop there or go further in? And then you can come back to the parts you want to come back to.
No, because I think that if we're going to do this, first of all, we're going to need information from the actual mechanism that we currently have, who is able to make these like calculations, payment models, healthcare capacity. We need this information, and the blueprint it doesn't necessarily mean that the blueprint will become this, but right now they're the ones that hold all this information. So I'm recommending that we keep this in here.
Well, then maybe we need a different header because the header says payments to practice. I mean, I just not want to make the assumption that that's a given. And that's what I'm stuck on.
Well, that's what's,
I listen to.
I get what you're saying.
I think maybe it will make more sense when we get in a little bit.
Well, because it's not necessary for the blueprint success. We're not saying the success of it, what's in our intent language, we're saying the blueprint.
Yes. I don't think it's implying that the blueprint is solely responsible for meeting the intent of the bill.
I don't, but that's what but yeah, I mean, you agree with, I'm not sure what you're saying.
Right, I think this is still, as I understand it, there may be interest in continuing to update some of the blueprint statute provisions to make the blueprint more effective in its work now.
In its current state.
Yes, even as you explore using something not the blueprint to move forward toward universal primary care.
And
Okay,
then if it said that, like, in order to make the blueprint more effective now, terrible language, I get it. Then we should do, whatever. I just feel,
Do you want to take out blueprint success?
yeah, I would be good with that.
Yes, I'm sorry,
So
Larry.
maybe take out the word success, but I mean, blueprint is what we have and have had here for a very, very long time. And I would be very concerned about passing the bill. That makes it sound like we're not looking to
Yeah.
continue investing in blueprint and potentially there might be something else, but.
Yeah.
and it might be, it's
No,
part of the
that's it.
transition.
Yeah,
It's gonna be part of the transition.
Right.
That's what we have.
it's about assumptions that it will be the thing as opposed to allowing us to look at other possibilities.
I don't think this changes.
I don't think
that.
this changes it.
I don't.
I think this,
want to make sure we're doing.
it,
Looking at other.
it needs to facilitate development of sustainable payment models. Because right now, the payment models are not particularly, and in this bill, we're sort of asking them to look at payment models and develop payment models,
Say,
the blueprint.
and is that in a blueprint charge? They do it later. The reports are later. Those reports.
That's in the reports. And it's it's kind of, if you read the bill, the whole thing, it's almost like you can see it's trying to get somewhere and it's doing these things to try to get somewhere. It just didn't feel like it knew where it was trying to get to. So I don't think we should throw out the things that the information that we need necessary to get to where we want to go, because I think it's actually quite valuable in the bill. It doesn't necessarily mean that, we're building this and creating, we're not creating anything currently that the blueprint isn't already doing. We're just using their resources and framework to collect the information that we need to make good decisions going forward. And that's what I think this does. Right.
And to that point, we have reviewed this and heard testimony on it already. I hope we could try to maybe focus more on zoom out and look at how all the pieces fit together and decide what's necessary and what's not versus zooming in and hyper focusing on detail because it takes a lot of time and then we don't change anything after the big discussions. But I don't want to silence people. It's just a suggestion that we try to step back a little versus zooming in. It's like the Western mindset is to zoom in on a piece and fix a little piece of something and not look at the big picture. And I think right now, this is what you were just talking about is a big picture. It's a vision. It's zooming out and being where do we want to go from here? And what do we have to do to get there? So I just wanted to throw that out there.
In order to facilitate development of sustainable payment models, Health insurers shall submit to the Agency of Human Services at least quarterly or more frequently upon request all information that the Director of Blueprint deems necessary to perform a comprehensive. So why don't we just get rid of necessary for the blueprint success? We're still having the blueprint do
Yeah.
it. It's,
Yeah.
how's everybody feel about that? Okay,
Yes.
Well, so, okay, then I think this may need to move. I mean, right now, we're in this subdivision 1 is health insurance shall participate in the blueprint as a condition of doing business in the state.
oh yeah, but we're still having the blueprint do this, so it should stay with the blueprint. We're saying that the director of the blueprint needs to perform a comprehensive fiscal analysis.
Right, it just seems like it's related to participating.
Yes.
Right, like I don't agree with taking it out.
Okay.
I just feel like. Sorry, I just feel like I mean, this is about the blueprint. And so why would he be doing an analysis that isn't necessary for the blueprint success?
Because the analysis comes further down of all the things that he's looking at.
I think that's in a different section. That's not,
Isn't
this
that
is
what this
becoming, no, this is amending the blueprint statutes. We get to this section on the reporting, blueprint payments to practices, primary care report, all of those various 9 provisions come in an independent section.
So this is just report 1?
This isn't
This isn't even
reporting.
a report.
This is just amending the blueprint statutes.
I know, but I'm trying to figure out what that new language, why it's even in there.
Can I speak to that?
Yes.
I think we're trying to do 2 things at once. I think that the first thing we're trying to do is support the blueprint in their work. As, you know, we have this interim time because we're not gonna have universal primary care anytime soon. So we want to support the blueprint in their work and also their contribution to getting to the next level. And then there's the work that goes on with getting to the next level, which is report ABCD. So I'm just wondering if we do both, which I think we should, but maybe move this section later so that, because our intent is about universal primary care eventually, and that's what we want to move towards and also support the blueprint. So that's what I'm seeing if this bill wants to do both. I think we should. I think supporting blueprint's great because they provide clearly important work, but I think that we're conflating them.
I think in the bill, as it came over to you, because it was built on the blueprint, it made sense to kind of go right into the blueprint and then how it's going to be used. I think, you know, if there's interest in updating the blueprint statutes and also pursuing universal primary care, I think you're right that maybe flipping those. So we go from the intent right into whatever, some gathering information to move you forward makes sense.
Okay.
I just want to make sure we're not losing
No,
like
no, I agree
blueprint
with
as
that.
a
We're not,
base.
yeah,
I don't think that's the
absolutely.
goal.
There is no
I think we should need to do both. That's what I'm thinking.
clear.
Later in bill.
Okay. Move later in the bill. All right, next.
Are you wanting to look at top of page 3? Is that where we?
Yeah, we're at the top of page 3.
Okay. And so again, I don't know with some of these sort of technical-ish changes to the blueprint language, I don't know how many remain appropriate if we're not using the blueprint as the base, like changing terminology from medical home to participating practices. I'm looking to KHS and BMS. I think this may be something that the AHS folks need to maybe make some recommendations based on where you are and are not going.
I am going to recommend that we leave this entire section, not the entire section, but this whole C1, C1A, B, C, the next page, all the way to page 5,
710.
to the 710.
Yeah.
I'm suggesting that we leave all of this because we're still trying to sustain the blueprint.
Exactly.
We are not trying to.
Yeah.
My only question is really around this particular. Right, is it not? It's something weird. I'm not seeing it.
There was in, on,
Because there's the reference to changing medical homes to participating practices because the intention of building these payments on top of, okay, building these payments on the blueprint was expanding per member per month payments beyond just the current blueprint medical homes. And I just don't know, is this still updating, you think?
I think it's just updating.
I think 5 years to get this through. I mean, who knows?
Jessica Varner for the Vermont Medical Study. Yes, I think this is still focused on the current blueprint program and things like trying to integrate the Women's Health Initiative and the patient-centered medical care programs and just calling it one thing rather than like out different things. So this is not really anything. It's more about just
Cleaning it up.
Yes.
You know how Dr. Soroyan comes in and he gave that big list and it had all the numbers of the money on it? It's about aligning all those things under one, so it's not broken out by like the CHT and the math and the this and the that. So I suggest that we leave the bill as is.
Okay.
All the way
All of
through.
706 here.
Yeah.
That's kind of what I was.
710 is, 710, I think you have to stop and
So 710,
I don't know if you want to hear from AHS. I see Eli has a hand up.
oh, I'm sorry, Eli. I'm sorry, I didn't even know you were here.
No worries. Eli Howgett, Agency of Human Services. I would suggest as well leaving the data section in, and if you'd like to also replicate it later on in the bill, but that data section was written in mind with blueprint modernization and wanting to have those data components to inform our current initiatives and our initiatives moving forward in the next few years. And as Representative Golden said, right now we're in an information gathering piece that you're speaking about, the future of universal primary care. And so we do want to maintain an eye on the current system and Blueprint's continued ability to gather data.
Yes, I'm suggesting we leave this in. We need to modernize the blueprint. No matter where we go, we still have to modernize the blueprint.
Does that change the intent section or just leave that be?
No, the intent section is gonna change. And then we're gonna go into modernizing the blueprint, which is what this part is.
No, I was wondering if we had to add to modernize the blueprint. Do we need to that?
No.
Okay.
Because modernizing the blueprint is necessary if we're gonna move towards a primary care system that's.
I don't know if it's necessary, but
Well-
I'm willing to keep an open mind.
Anyway, that being said,
There we go.
what I wanted to say was that I appreciate the suggestion that we not touch as much as possible, because I want to remind everyone, the Senate spent months working on this, heard testimony, created this language, and we heard testimony. People weighed in on this. This is all, I think, unless someone was taking notes of any problems, this has all been vetted. So I don't want to mess it up. And then I'd rather just like do what the chair said and focus on how do we end the bill? How do we, it's like someone gave us a story and they didn't write the final scene. That's how it feels like. So maybe we could write the final scene, send it to the Senate and hope they like it. If not, maybe we'll go to conference committee at this point because it's not a lot of time. So.
Okay, so we get to 710.
So for 710, I'm not sure it makes sense to keep this in the blueprint statute if you are not, or blueprint subchapter, if you're not having the blueprint do the, if you're not having the blueprint direct increased spending to the per person per month payments. And so, you know, I think you can take some of this aspect of of the agency establishing a target for the amount of per person per month spending on Vermont residents that should be primary care with the transitional schedule and adjusting targets, but maybe you put that as part of their section 3 report and not as a part of the section.
So take the things out of it that we want them to do. Strike this section. And keep in the stuff we want them to do, learn it into the blueprint payments practices primary care report.
I think the first 2 sentences, or largely the first 2 sentences, can go into that report. I think there's some, to some extent in there and somewhere else. So I guess there's there's a separate, currently a separate section on, for section 5 is primary care spending targets report. So you could either have a separate report or you could have one report.
That was one. I always would choose one.
Well, speaking of, the next thing is, oh,
For the record, no language on fiscal, are you taking up, can you go back up, Jen? Are you taking up the language about, per month spending?
yes,
They're taking out, well, they're leaving in this concept of establishing a target, but taking out the increased spending shall be directed to.
My only suggestion would be just take out the words per member per month, say the target for amount of spending.
Yeah.
Because of HR1 concerns.
I think that
I don't know.
we're basically, this last sentence, the increased spending shall be directed at the per member. I think we're striking that whole thing.
Up on top of the first sentence. Shall establish target for the amount per member per month. Is that staying in or is that coming out?
I think some version of that was going to stay.
I'm just saying,
It's a report on targets.
okay, I still might just take out per member per month, just
Okay.
because conversations I've had with AHS around.
And
They have to start rethinking how they're gonna be doing
Yes.
payments in the future because of state directed payment concerns. So I think you still can have the concept of
Concept
it,
of spending.
spending, and maybe they just don't call it a PNPM
Okay.
statute.
Okay,
I
got
know
it.
Jessa may disagree with me on this, but this is based on a conversation I had with AHS.
Thank you.
So I don't think it changes the intent of it, it just makes it a little more vague.
Flexible, yeah.
Just Barnard Medical Study, just to make sure we're all talking about the same thing though, just to be clear, this is about how it's measured, not about how it's spent.
Okay.
Practices is not saying that they have to be spending in a per member per month way, it's just saying it's like a way to equalize how we're measuring between payers, how much they're spending on primary care. So when at least, maybe AHS would like to comment in earlier conversations with that, I don't know that this flagged state directed payment issue, because it's not about how AHS is paying, it's about how we're measuring how all payers are.
Well, I see establish a target for the amount of spending, so to me, that is potential spending. But I'll leave it to the lawyers, but that's my concern.
What if we just said per person spending on
I think
Vermont
just leave it as
residents?
spending. Just leave it on the amount of spending of Vermont residents, they can measure it, it's just
I
not
mean,
putting it in law, that's.
yeah, I mean,
anything.
we get the Medicaid report every quarter and it has basically how much per member per month the spending is.
Because we're still legal.
Yeah, well, no. But it's not actually it's not how we're spending the money, it's just, I mean,
I'm just cautious, I'm not aware, I'm just flagging the concerns that I had about any future potential spending, that's all.
okay, well, we're establishing targets for the amount of per person spending.
I agree with Noah. Let's just leave it spending and it'll evolve.
I'm flagging, I'll
I
let the
think-
lawyers determine it.
Yeah, I think my concern about just saying spending is that you're gonna end up with one large number that doesn't tell you
Yeah.
what it actually
But I think
costs to provide primary care services to an individual.
Per person spending,
Right.
that would. Can we?
In measurements, it's one thing, it's nothing to just, when you're saying targets, then it becomes potential spending, that was just. my
No, but it
concern.
doesn't, I mean, it doesn't have it coming from Medicaid or private insurers or Medicare or.
Well, I'll just read this again. So maybe like right now, we know it's 5% of, going to primary care, but we want to go up to 35 or whatever we want to go. But see, that's what I'm just saying, how much residents should be paying for primary care services so that we do want to increase the amount of spending.
We have to
increase the spend.
We have to establish a target.
Or we
For
have
the
to-
amount of per person spending that should be for primary care.
Well, the 5% versus 35 is the whole system, right? It's not.
That's what we're asking them to do, is to establish that.
But what we use those numbers, when we say 5%, that's for the system, not for the individual. Where does the 5%, 35% come from? When we say the 35% is
That's the
spent,
system.
that's the system. So I think we should stick with system.
Yeah, but that's not what we're asking in this thing to do. We're not
No,
asking
but
for
that's-
how much we should be spending on primary care. We are asking, what is the target amount that you should be spending per member on primary care? That's
per
what,
member, because the next sentence is that they have to be able to be adjusted to reflect their specific differences like age and health status. You can't do that with one lump sum.
No, it's very confusing.
I thought we were
I'm going to list that. I think we need to move on. I think
We are
say
striking
per
this,
person
we are
spending.
striking this section.
I'm sorry that I brought it. I mean, Jen's right. It's not Medicaid specific.
Okay.
It's-
It's just how we measure how much we're spending.
I was just flagging it, sorry.
Okay, well, I will tell you that the last one, so the increase in pay shall be directed to the your health payment. So that's gone. Okay.
So you want to go per member per month back? Line 9?
I'm fine with per person spending, but if people want per person,
Person, and because I'm thinking, that's where I got stuck.
Like per capita?
this is a target that they're doing an analysis of what that
I withdraw
target
my
amount
remarks.
should
I'm
be.
sorry that I.
Too late.
Okay.
I'm
No,
not-
look, so everybody, I'm not getting into the weeds with this. We're gonna strike this and we're gonna take the pieces that need to be measured and we're gonna put them into the report of what they need to measure. And then we're cutting everything else out. So on to how many reports this is gonna be. We changed January 1st to January 15th because there's.
Yes, I changed from
multiple things.
Yes, January 15th throughout. I'm not sure why we ended up with January 1 on just these few.
Okay. So the next thing,
I don't know that this is really blueprint payments to practices anymore either, but it's some kind of blueprint information report.
all right, so this is the blueprint in consultation with all these things. They, by January 15th of 2027, they should report on. So number 1 says define which services should be considered routine primary care.
Right, but I think you have to do the lead-in because I don't think you want the lead-in anymore.
Ah.
So on or before date, report on changes to payment amounts or payment reform methodologies or both that are necessary to transition the blueprint per person per month payments to primary care practices to include payment for the routine primary care needs of attributed patients who are covered by participating plans. That's using the blueprint as the basis for your
Future state.
yes, for your future.
That's what, because it's not a current state question, it's a future state question.
Why don't you want to start it with that?
I don't understand because we're not trying to break down the blueprint. We still
No, but you're
want the
not trying to
blueprint to.
transition the blueprint's existing payment structure to include payment for routine primary care needs of attributed patients who are covered by participating health plans. That's not universal primary care.
Right.
That's using I mean, it may be a way of getting there, but it's doing it based on the blueprint. Using the blueprint as the mechanism. If that's what you want to do, that's fine. That's what it currently says. But if that's not where you're wanting to go, then I think you need to modify
All right,
what
so
you're asking. And
so shall we remove the regarding changes to the payment amounts and payment that are necessary to transition the blueprints per member? Should we just get rid of that whole part?
probably, I think you're looking to have a report from the blueprint more generally on some of the items in this list.
The 1 through 6, I mean, the items are great. If they can report on the items, but not with the assumption.
All right.
Yeah.
Okay, so we stop after regarding.
Yep.
And then, okay, so we started with number 1. It says define which services should be considered routine primary care. I've asked Jen to include in number 1 only because it comes up almost in every single bill that we do, to establish a definition of primary care and primary care provider. Because there is no, like, Jessa, I can see Jessa laughing over there. So,
And define which
And,
services.
yes.
Well, and I don't know if you want to continue to say, define which services should be considered routine primary care, or if that's not relevant.
oh, no, I think that,
Construct.
no, I think that
That's universal.
that's really important.
Okay.
Because those are the services they provide, not providers.
Right, but it's which should be considered routine primary care, is that's
Is routine primary
Because-
care, is that what you're saying? Is that the phrase? you're
right,
using?
because that was a piece that was being what the bill was looking at doing, particularly as originally introduced, was to have a per member per month payment to the practices to cover all of the costs of providing routine primary care services. And so it was important to know which services were routine.
Why don't we just take out routine?
I don't know why we're not leaving this. Because if we're ever gonna develop a methodology, no matter what we go with, we have to figure out what the services are that are going to be considered routine. And then, because there's always going to be an aspect of additional services that are not typically routine that will need to be performed. I think that's what.
You want
this-
definition of primary care providers and which services should be considered routine primary care.
Okay, let me ask this question. Like, I'm thinking about abdominal pain, right? You want to go see your primary care provider because you have abdominal pain. Is that considered routine primary care?
Yeah.
Yes. So that's, but maybe in some worlds it's not. I mean, because then you end up.
See your primary care provider and they excise a 6 centimeter mole off of your
eyelid.
face, your eyelid.
Sorry. I had to go there.
A 6 centimeter mole off your eyelid would be big. Is that's what it's trying to get at. Is that considered routine primary care?
Yeah,
That's, well.
we had providers say that. I want to, but that was.
Look at the report.
Stop. But that would be a fee for service.
Stop. We need them to tell us
Yeah.
what do we consider routine primary care? Somebody's got to make the call on this. Okay, address any differences in methodology, make
Different
recommendations.
practice types, does that
Different
make
practice.
sense?
Yeah, it does. Pediatrics, family medicine, OBGYN, if they're considered primary care. Make recommendations regarding risk adjustment and attribution methodologies. We need that. Remember, this is what we're tasking them to do in this report. Describe the ways in which the methodology will.
We have the methodology. We
don't have them with a methodology.
I think this is, I think this is when you get into somebody recommending how to pay for it. It's perhaps when you get into methodology.
Could you say which various methodologies or, I mean, because there's maybe there's one methodology here and maybe there are various ways to skin this cat, as it were.
So identify methodologies, that
Yeah.
will balance capacity.
Yeah.
volume.
Yeah.
Images in my head.
All right.
Sorry.
Include mechanisms for ensuring that healthcare make accurate and appropriate. I don't, we need that.
Not sure if that's as relevant to your current,
I don't know where that came from. Though.
right? Maybe we get rid of that one. Leave room for others.
Well, keep number 6. Daisy, aren't you gonna be like so happy with me?
You're keeping number 6?
Yes.
Sure.
I don't think we need 7.
Not sure at this point you do.
Okay. And this is where you had inserted the language from that struck.
I think so, about, yes, I think you could, and maybe instead of number 8 at this point, you have the primary care spending target piece from,
Yeah.
took out of the
That earlier.
yeah.
So keep
Primary
providing
care spending.
analysis of ways to incorporate the primary care spending allocation
Well,
target,
I wasn't gonna keep that. I was gonna replace it with
replace it.
with the primary care spending target. Language, all right. And then,
Oh, and then we had the last one, provide an operational plan and description of legislation needed and a timeline for implementation.
right, I think when we were talking about it this morning, we were just talking about taking out some of the date language and putting in, yes, an operational plan, timeline, or, operational or implementation plan, and description of timeline and description of additional legislation.
Yeah.
But needed to implement what? Because right now you're
Right,
just
we're not-
asking them for some information, so maybe maybe that's premature. I think it might be premature.
It's premature too.
All right,
You don't want them to come back if they need any further legislation after.
Well,
they're not doing anything yet, they're
Doing
just giving you information.
we have a note in here about blueprint maximizing delivery of existing blueprint services. Was that, we were adding to the report that they needed to,
And I'm looking at my notes.
how they were maximizing the delivery of their existing services?
Oh, I think you were interested in something down, but it's not this, but yes, the blueprint, or, in order for the blueprint to maximize the delivery of existing blueprint services, what are the funding needs for each aspect of the blueprint? And include and how much that would be, or that would be in the per member per month blueprint payments, something like that. You were wanting them to report separately on the costs,
Yeah.
like if Blueprint were operating, I think the maximized part is that the Blueprint were operating at sort of, it's, the peak of its intent of the, the intent behind the program. What would be the additional funding needs for each, hub and spoke and community health teams and,
So
Consult initiative, whatever it is.
resources required to,
right,
to
yes, resources required to enable the Blueprint to
operate and deliver at its maximum needs or yes. I would,
That's like that.
Yes.
what are we not investing because we don't have the money to invest in it that could be used? I know that we are, I know what time it is, everybody.
It's time for universal health care. Just kidding.
I'm really sorry, but my brain just stopped working a minute ago. I'd like to take
need a
a,
break?
I need a 10-minute
I
break.
think it's a good idea.
I